Good morning and welcome to our Sheffield Pancreatology Symposium. Thank you for joining us today in what we hope to be a morning of education and collaboration, including the topics of acute pancreatitis, chronic disease and pancreatic cancer. We hope everyone involved in caring for patients with pancreatic cancer will be able to learn and improve their practice from the talks that we've got planned today from our panel of expert national and even international speakers who have given us their time this morning. I'm sorry we can't invite you to Sheffield for the symposium, but I'm glad that our production teams in Sheffield were able to be able to stream this to continue the concept of education throughout this period. They managed to bring together this morning over about 350 registrants this morning, and representing the multidisciplinary teams of nursing, dietitians, radiologists, and medical and surgical specialties. The meeting's been made possible by a unrestricted educational grant from Dietetics, who weren't involved in the content of the meeting, but have enabled this to be a free meeting for all. And we've also representing the British Society of Gastroenterology education section on this this morning as well. Given how the format's changed multiple times in the response to travel restrictions, this meeting is now completely virtual. I'm not even really allowed to sit next to my co-chair that you'll see in a minute with the going off camera, but and a lot of our local faculty also aren't able to be here. So therefore, we're going to ask questions after each talk, so please be keen and use our the blue box next to where I'm speaking now, the slido.com, which I'll show you in a second, to ask questions, and then we'll put them to our speakers after each talk as we go along. At the end of the meeting, there'll be a feedback form, which if you fill that in, you will then be issued with a CPD certificate for the meeting. So we are going to be going through in quite a rapid succession this morning of all the talks that we've got, and we will start the first session by, I think, asking our team for a poll. If you can use that Slido box that should have appeared now to actually see what specialty you're representing this morning, and see who's with us, really, and that'll just really help us sort of maybe just adapt the meeting as we go along. So we'll update you probably with the results of that as people start coming in, which is great to see people are using that already. And I'll hand over to my co-chair, Mark Peterson, to start introducing the first session.
Thanks, Andy. Our first speaker today is Mary Phillips, who anyone in pancreatic disease will instantly recognise as a professional and academic who's been involved in the improvement of care for pancreatic patients for over a decade now. Mary works at the Royal Guildford Hospital in Surrey and is currently undertaking a PhD in the long-term effects of pancreatic surgery and effects on our patients. And Mary is past president of PancSoc and is here today to tell us that, unfortunately, we're still doing it wrong. So, Mary, look forward to hearing your talk. Thank you.
Thank you. Thank you. So, thank you for the kind introduction and the invitation to speak today. I'm going to talk about pancreatic exocrine insufficiency and why we're still not getting it right. So I'm going to cover where we are now, what we're doing, why is it so hard, and if there's anything we can learn from other disease states and where we go from here. So first off, where are we now? Well, we have a definition. So we know that pancreatic exocrine insufficiency is that failure of the pancreas to secrete sufficient enzymes to achieve normal digestion. We know the incidence of PEI, we know that it's progressive in chronic pancreatitis and in inoperable pancreatic cancer, and that there's a high prevalence in acute pancreatitis and operable pancreatic cancer following resection. And we know how much to give. We have consistent guidelines that give starting doses of between 25 and 50,000 units with meals and half that with snacks. We also have NICE guidelines saying that patients with chronic pancreatitis should be monitored for PEI. They should have access to a dietitian, and patients with pancreatic cancer should be routinely started on pancreatic enzymes. And those enzymes should be considered in the post-operative setting for those with operable disease as well. So we have all this. Are we doing it? And we know from the Ricochet study that less than 50% of patients are on enzymes. And historically, and these studies now are 9 years old and carried out in the Dutch population, that patients, even though they are started on enzymes, are often taking low doses, have ongoing symptoms, have poor access to a dietitian, and are following unnecessary dietary restrictions. And certainly in my clinical practice, the patients that are referred in, I'm not sure that's changing. So why is it so hard? So I'm very aware I'm speaking to the converted at the moment. So where people are interested in this and do this regularly, this goes right. So it is just in these patients are all over the place and not always accessing specialist services. And consequently, if you don't know about the guidelines, you go to the resources you have available. And this is the current BNF advice. So enzymes are in alphabetical order. On the BNF, which means we start with a Creon 10,000, which gives you an initial start dose of 1 to 2 capsules, no mention of snacks. You go through to 25,000, again 1 to 2 capsules, no mention of snacks. And only when you get to N in the alphabet do you get the concept of a dose for snacks. And we go on through the products that are available. Once we get to Pancrex, we've got this concept of sprinkling on food, which we absolutely do not advocate, except in very specific circumstances. And then when you look at dose adjustment, there's also some advice in the treatment summaries on the BNF for this as well. But if you look carefully at the wording, we've got that pancreatin should be administered with meals and snacks, excellent, and the dose should be adjusted as necessary, but to the lowest effective dose according to the symptoms of maldigestion and malabsorption. And that kind of implies that we should be reducing the dose once we've started it rather than escalating it. So it's not really surprising that inexperienced prescribers surrounding enzymes aren't necessarily getting that initial dose or dose escalation correct. And then most importantly, all of our patients are different. We all eat differently. So around the world, the number of calories consumed from population to population covers an area of over 1,000 calorie difference from different populations. The concept of what our diet consists of is very different. This is vegetable consumption in Europe. And you can see even in countries that are geographically adjacent to each other, say France and Spain, for instance, there's a twofold difference in vegetable consumption between those populations. So what we eat, as well as the quantity that we eat, is different. And within the UK, there's a huge amount of work that goes into British national dietary surveys. And this study identified 13 different meal patterns within the UK, and no more than a third of each gender falling into one of those categories. So there's a massive variation in what we eat. And we have to remember in the clinical field, that's not just necessarily food. We have oral nutritional supplements, whether they be in drink form or in powders or jellies or shots. And also we have those patients receiving enteral nutrition. So we don't have a one dose fits everybody by any stretch of the imagination. And then there's further variations as well. So this study was published just a couple of years ago now, and put a very interesting twist on the factors that implement our dosing. And this was a study carried out in cystic fibrosis, and they looked at labeling stool to collect feces to allow for that coefficient of fat absorption to be calculated on different treatment schedules. And what they found was that there were a number of different variations, but the most statistically significant was in fact transit time. And when you look at our patients, we have the use of opioids, we have prokinetics, we have antidiarrheals, we have all sorts of factors, plus surgical resection. And those will be very individual and will vary with time. So ultimately, when we've got the enzymes right, we've also got the patient factor. And this was a study carried out in Sheffield that looked at the impact of pancreatic enzyme replacement therapy on patients in the post-operative setting. And patients identified that despite advice, they still felt confused, they struggled to take it all in, and the enzyme dosing was the hardest thing to cope with after surgery. So we've got a huge number of different factors floating in here. So what can we learn from others? Well, there are other diseases with a clear nutritional pathway and clear follow-up processes in place. So if you look at celiac disease, for instance, or diabetes, but the difference is we have a method for assessing treatment outcomes, we have a method for assessing long-term adherence, and we have clear guidelines on follow-up and what that follow-up should entail. And we also have access to specialist teams and celiac disease in most hospitals and in diabetes in primary care as well as secondary care. But access to support in PEI is mainly, not always, but mainly restricted to tertiary centres. And when you look at the models for celiac disease and diabetes, we've got clear models in place for those. But for PEI, it's part of a bigger picture. And the problem is that PEI is a symptom of disease. It's not a disease in its own right. So changes in symptoms are closely linked to disease progression in both benign and malignant disease. And the average GP will have 4 or 5 patients on their caseload. So it's unlikely that we're able to justify resources in primary care or even small secondary care to provide expertise for these patients. And ultimately, we don't have generic advice. Each single one of these patients is different. So where do we go from here? Well, if we could put a wish list together, regardless of our source of wishing, we would ask for individual management for our patients. We need a robust screening process for both diagnosis and efficacy of treatment, and we need repeated access for patients to gain information. But unfortunately, money doesn't grow on trees, and we don't have an infinite supply of clinicians in this field. So in the interim, we need UK guidelines that are specific to PEI, that are practical, that support that structured assessment, clinical evaluation, that make recommendations regarding routine follow-up, and that cover PEI outside of chronic pancreatitis and cystic fibrosis. You'll see the majority of the literature is within those fields and the guidelines within those fields as well. We need to cover how to dose escalate and when to look for comorbidities. And that's really important because it's not just a matter of escalating and escalating doses. There are a point where we need to stop and think, are we actually treating the right thing here? And that's also really important. So just to conclude, PEI remains under-recognised and many patients are on suboptimal doses and receiving correct advice. Multiple factors play a role in dose adjustment, so we really do need individual management, and we need to empower the patient to dose escalate. We all eat differently. Some of us have snacks that are bigger than meals, some of us graze throughout the day, some of us only eat once or twice a day. Everybody's dose requirement is different. There's a lack of follow-up for patients regardless of underlying disease, and we need an agreement on where the responsibility lies for that follow-up, whether it's in secondary or tertiary care. I think it's unlikely it should be in primary care, but those decisions need to be made. So I'm just going to finish with a rather shameless plug that those guidelines we've been mentioning are on their way. Unfortunately, they're not quite ready to be launched today, we were hoping for, but hopefully they're coming very soon. Thank you.
Mary, that's a fantastic opening talk, and thank you for starting this meeting with such a comprehensive overview. Looking at the poll, we've got a significant number of dietitian colleagues with us on at the moment, so about 30–40%, along with a lot of trainees as well. So I think it's really, the message is getting through, as you say, some to the converted and some to our trainees coming through. I think you did mention there about patients with pancreatic cancer, and I think maybe Keith Robert might speak about this later on, is that the ricochet data that came through is that we were still finding that only less than 50% of patients with inoperable disease are actually getting prescribed enzyme replacement, when there is such good evidence to actually, that's the one thing that we can really help in the best supportive care is nutrition, not just enzyme replacement, but just nutrition as a whole. Is that because lack of dietitians? Is it because of lack of education? Is it lack of the guidelines you just talked about? What do you think about that?
I think it's probably a multitude of factors. I think there's such a lot going on in that new diagnosis stage. Patients are often eating poorly. They're often on doses of other drugs that will impact on that ability to make the diagnosis of PEI. And perhaps it's not a priority for all patients right at the very beginning, or not perceived to be. So I think it is very difficult. There's such a huge amount going in with providing support for those patients that it's easy to see how it gets missed. How we go about changing that, I think, is just awareness and a recognition that steatorrhea is not the only symptom of PEI, that it is a very late symptom, and that in patients following low-fat diets or on constipating medication, the symptoms are really not that obvious. And I think a lot of the time we rely very much on symptomology. And until we have a really robust diagnostic test and the protocols to put that in place at diagnosis and when it's required, I think blanket supplementation is probably the safest route to go down, and it's just a matter of awareness, I think.
Questions from our delegates now is, can we give too much enzyme replacement? You hear reports sometimes saying that people have constipation or things like that, and is that GI side effects that they're getting from their disease, or do you think you can actually give too much enzyme replacement?
I think we all will have the odd patient who really does struggle with higher doses of enzymes, whether that's a side effect of the drug. Constipation is really difficult to manage in this patient setting because there are so many factors. So making sure your patient's drinking enough, moving around enough, they're not on constipating related medications. And we quite often use laxatives alongside enzymes. And I think that's where your marker of effectiveness of the drug is really important. So if your patient is on enzymes and they're eating well and they're still losing weight, or they're still having nutritional compromise in other factors, then that's where we need to look very carefully at the use of laxatives alongside these. In terms of high doses, so historically in the literature, we can't hide away from the concerns that were raised about fibrosing colonopathy. I'll be honest and say in 16 years working exclusively in pancreas, I've never seen a case. But there obviously is that data in the literature, so we do have to be aware of that. More commonly, we might see anal irritation, very high dose enzymes, but usually that's associated with very fast transit and settles as the transit time reduces. In terms of constipation, yes, I think there probably are some patients who will always make that link. I'm not convinced whether it is there or not, but we do have to bear in mind that enzymes are a significant pill burden, so we don't want to be over-treating. It's obviously not a cheap treatment process, but it is also a significant pill burden for patients. And if you're struggling with poor appetite, taking 5, 6, 7 capsules with a meal, and the water that you need to swallow those with is going to have an impact on appetite as well. So I do think it is important that we do stick to the lowest effective dose, but we just need to be careful that we are at an effective dose with it, if that makes sense.
Very much. Last two questions then quickly. I think acute pancreatitis enzyme replacement, when do you start straight away without waiting around for tests or things?
So it's our practice that any patient who has any nutritional compromise with severe pancreatitis goes straight onto enzymes as soon as they start eating and drinking. So it takes a while to get function tests back, and that's a time period that patients can worsen their nutritional status significantly. The incidence of PEI in acute pancreatitis, particularly around patients who've had significant necrosis or the presence of pseudocysts, is high, and I think given the severity of malnutrition in this patient group as well, it warrants routine supplementation early on in their disease status. It's our practice, once the patients are home and they're well, to at that point assess their exocrine function and consider stopping. We know some patients can come off enzymes, particularly those who've had very edematous pancreatitis, but certainly those with extensive necrosis and the presence of pseudocysts, we would routinely start.
Fantastic. I think, and then the last question I think is the fecal elastase measurements. I think there's it says here about there's a question here that's got quite a few likes, which says, can we measure fecal elastase in patients who are already on replacement therapy? I think a lot of diseases, as you just said, we don't even measure the fecal elastase before starting therapy. But can you comment on that for me?
Yep, there was some concern when the new polyclonal test came out that there may be the ability for fecal elastase to detect porcine enzymes, but studies have subsequently shown that not to be the case. So yes, you can do fecal elastase on a patient who is on enzymes.
Can I thank you so much for helping this morning? Thanks so much for your time